Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's membership, offering members special discounts, clinical resources, and unlimited free CEs, with information on how to join available at www.aacn.org/discoverAACN. Now, here are your hosts, AACN's Chief Clinical Officer, Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. I am Vicki Good, and I'm joined with our co-host, Andrea Schmidt.
Hi, welcome to the podcast.
Andrea, it's hard to believe right now while we're recording this episode, we're about to come upon a significant milestone in healthcare. The first COVID-19 cases that impacted the United States occurred in March of 2020. Some of our listeners may not have even been a nurse then and have not experienced the pandemic through the role of a nurse, but I'm sure they've heard all of the stories from their colleagues about the impact and what they went through. And as I reflect upon this time of uncertainty, I just remember where I was at. I was the director of patient safety and infection prevention at my hospital. And it was just such a time of uncertainty. I was juggling everything at the hospital, trying to figure out all the changing guidelines and then listening to the national experts, but then also managing my personal impacts at home and the disease. Andrea, what was it like for you in the hospital setting?
It was a very scary time, I think, due to all of the unknowns, especially in the beginning. So I'm in the Midwest, and we were watching what was happening in New York in particular and how quickly people were getting ill and dying. And while we were making preparations for our first patient, trying to keep up with the mixed reports, is this airborne? Is this droplet transmission? What happens when we run out of negative pressure rooms? Do we have enough PPE? How do we not contaminate ourselves? And really making sure that everybody was donning and doffing the way that they were supposed to so they didn't contaminate themselves. And I think as the virus evolved, along with treatment and safety recommendations, our team really relied on our organizational experts, infection prevention, but also AACN, and to help guide with practices like proning so we could really learn from what others were doing and make sure we were doing the best we could do for our patients.
Yeah, and AACN was really watching on numerous different fronts. And one of the first things they saw was that the National Institutes of Health put together a COVID-19 treatment panel to generate guidelines and to guide us in healthcare. But they noticed one thing. There was no nurses on that task force, which was a big miss. And we needed to have the nurses' voice present. So AACN immediately advocated for nurses and contacted NIH and said, we really need somebody on that panel to represent the nurses' voice. And so that brings us to our guest today, who is John Gallagher, who is a longtime AACN volunteer, a former board member, and just an incredible critical care expert. John was uniquely qualified to represent critical care nurses. One, just because of his vast critical care nursing knowledge, but two, he was also a former respiratory therapist. So, John, before we dive into your work with the NIH panel, would you take just a few minutes to introduce yourself to the audience?
Sure, Vicki, and thanks for having me here today. This is great. So I've been a nurse at this point for 37 years. I had started out as background as a pre-hospital provider, and then out of high school went to a respiratory therapy program. And as I was there, I realized I wanted to do more and decided to go to nursing because it was really about caring for the whole patient. And so I started out in emergency medicine as well as respiratory progressive care with my background, and then went on to trauma and critical care. And that's where I spent the majority of my career as a staff nurse, clinical nurse specialist, and then went on to run the trauma program at Penn for a number of years. And now I'm in the university setting as a professor in the School of Nursing. And at the time when I was a board member, I had Connie Barden had reached out to me, and in her true way that she does, she says, hey, I have an opportunity. that you might want to consider and you might be qualified for. And, the rest is history. And that's kind of how I ended up on. But my background has been primarily pulmonary trauma and critical care. And I spent a lot of time in those areas and kind of helped it prepared me to do this work as it came forward.
Well, John, we are so thankful that you are here to share your story with us today. And on the task force, you specifically represented the specialty of critical care nursing, and in the beginning, also respiratory therapists because of your background. Could you tell us a little bit about the composition of that panel and what it was like to be the only nurse, and then initially possibly the only respiratory therapist?
Yeah, so when this happened, they reached out to me. I was the only nurse that was on the panel, and this panel had been pulled together, the actual direction to do so, in March of 2020. So normally guidelines are formed by professional organizations as well as the CDC. And the Health and Human Services came to NIH because they had experience in guidelines for HIV, and they asked them if they would be the point for these guidelines. And so it formed very quickly, actually within a few weeks. And the first set of guidelines were put out in April 21st, I believe, of 2020. And this was the first set of guidelines that actually predated me being on the committee. The committee really was all in about 65 people, and this included administrative staff, but I was the only nurse. And when I got on, from the standpoint of whether it was staff nurse or advanced practice, there was no other nursing representation, and probably for another couple of months, no respiratory therapists. So the reason that I had been brought on was for the critical care background. And in that structure, I would say initially, it was very impressive, the list of people that were on this committee and by background, what they had achieved. So for me, I was in awe of the group that I was with, but also realized that I was going to be the one that was contributing the nursing kind of lens to this, because of all these people, there were no nurses. So some of it was initially a bit overwhelming with the amount of information that was coming at us. And then a lot of pride in the ability to represent nursing, both advanced practice nursing, but also the clinical bedside nurse as well, and that perspective as these guidelines started to form.
Well, I mean, I just can't even imagine being only one nurse out of 65 people. So how difficult was it for you to raise your voice?
So in the big committee, when you think about it, about 65 people, we were on a Zoom call every Friday. And that was at least every Friday. And then there were 4 teams. And the clinical teams that were really looking at patient care specifically were teams 2 through 4. And team 4 was the critical care team. So when we were looking at guidelines, a lot of these initially being written, the first iteration was 91 pages. The last was 478. And so a lot of these were developed, the critical care guidelines, and that's where I spent most of my time, as well as our respiratory therapy representative as well. And we, as a group, we very quickly got comfortable with the team we were working with. And I think it was very easy, at least in that group, to speak up and give your expertise. In the larger group of 65, when we meet every Friday, each team would report out, and they were very inclusive. They wanted to know what we were missing, what kind of things were important related to the guidelines that we were developing, but then specifically around your unique aspect and your role in patient care. So on our critical care team, each time that we would discuss something, they would actually call out and ask you if you didn't raise your hand. If they didn't hear from you, they were very quick to include you so that you would be able to contribute. A lot of that happened on the front end of the guidelines when they were first being developed, especially because of the number of critically ill patients who were being ventilated. We had proning in there. We also had different types of, when you look at the surviving sepsis guidelines. Initially, what we had done with the guidelines is we had to adapt guidelines that had been out for critical care specifically and look at them from the COVID lens and to see how we could adapt them for use. And then as more data came in and as more research had been conducted on these patients, we could actually fine-tune this over time.
You talked a little bit about the sub-teams, and I know we oftentimes use a little bit of humor in the ICU environment just to lighten the load. And certainly there was a lot of heavy burden during COVID-19. So I understand you all used a little humor to name your sub-teams. Can you talk about that a bit?
Yeah, so I really took me a while to try to figure out why they chose the name. So our teams 1, 2, 3, and 4 were specific. Team 1 was really looked at prevention efforts, special populations. Team 2 was really antiviral agents. Team 3 was immunomodulators, and Team 4 was critical care. But within those, we actually had sub-teams of focus, and they named them after cats. And so we had Team Cheetah, Team Lynx, we had a Siamese team, we had a Bengal cat team, Jaguar, Puma, Munchkin, Calico, Panther, and last but not least, my subcommittee on pulse oximetry, which was the Himalayan team. And I did not realize, of course, the Munchkin team was the pediatric team. And I was like, I'm thinking they're talking about Munchkins. And Munchkin is actually a cat breed, which I didn't know.
I didn't know that
And the
either.
Himalayan team, who knew that those cats were prone to respiratory difficulty as well. So this is why they had a reason for it. And it was kind of something that was funny. In the end, when we all got together, they had taken a picture of our entire team, and somebody photoshopped little cats all through the group sitting on people's laps. So, but we had a lot of fun as a group, even in the sub-teams, whether it was our backgrounds that we were changing or joking around with each other or our out-of-office messages that we left. As a group, we became very close within the team itself, but also as a full committee.
I imagine, it's important to have that levity because I think otherwise, with everything going on, I think it would just cause too much mental distress not to.
Yeah.
Now, speaking of your sub-teams, so you mentioned the critical care team, but then also you had that pulse oximetry sub-team. So could you describe your work on those teams, particularly the impact of the skin pigmentation on pulse oximetry?
Studies started to come out and they were looking at hypoxemia in these patients. This is where we started to really notice these retrospective studies where large numbers of patients were being included. And we were finding and seeing that patients with darker skin pigmentation, although initially the way that they were broken down as retrospective studies was by race, self-reported race, but the issue is really skin pigmentation. And what we were finding is that those with darker skin pigmentation, we could see that pulse oximetry was not representing accurately the true oxygen saturation in this occult hypoxemia. So as a group or as a subgroup, it was co-chaired by myself and Carl Hinkson, who was the president of ARC at the time. We were the co-chairs, and we started to look at this as well as other members, pulling the literature and the studies that had been out. And so we saw this disparity in how pulse oximetry was measuring saturation in those with dark skin pigmentation. And so based on that, we actually made within the guidelines recommendations or kind of provided information about the cautions and the limitations of pulse oximetry, not only around skin pigmentation, but how you had to look at the whole picture of the patient and assess them because there's other limitations of the technology as well. But this was really kind of the call where, and from that, started to see that, because of this disparity, the FDA convened special committee or review to have commentary on this. And I believe that happened in 2022, or at the end of 2022. So part of what we did, again, was just taking the literature that was available, looking at recommendations for use and kind of summarizing it within the guidelines. And it was very enlightening. So that committee, again, was a specialty subcommittee. And it was kind of not just the respiratory part, but from a nursing standpoint, starting to realize, there were other things that we could do to improve this accuracy. People were using, depending on the patient's ability to monitor the pulse ox at a certain site, may have been using probes that didn't really belong on the forehead, but using finger probes on the forehead. Some of these things came out, and we started to wonder whether that, in addition to the fact these patients were in the ICU and were having hypoperfusion, which also impacts the accuracy of the devices, may have had an additive effect in addition to the skin pigmentation. And I can say that the studies and some of the work that we did added to the decision of the FDA. Actually, it was just released yesterday. There are draft guidelines for how pulse oximeters pre-market should be tested, and new technology coming out as well as existing technology. And I think that this had a tremendous impact. So, our guidelines and the work that we did, but also how we took that data, and I think it created awareness around the issue.
I think that is amazing work and something that really needed to happen so that as providers, we can have the best care possible and provide that to our patients. And I wanted to share that in 2022, you did an excellent webinar for AACN on the impact of this skin color and SpO2 detection of hypoxemia. So to our listeners, if you would like to learn more about this topic, you can find it on our website at aacn.org/education/webinar series.
And John, you alluded to this earlier, but clinical practice guidelines usually take months, if not a year or more, to develop. And certainly as COVID-19 unfolded, we didn't have months, to develop guidelines, to direct practitioners. So would you talk about how did the panel come together and develop these guidelines so quickly?
Yeah, it was quite remarkable when you think about it. The kind of order or directive was given in March, and the panel was formed very quickly. And 65 panel members, as we mentioned, initially not a nurse or respiratory therapist on there, but then that was rectified fairly quickly. The majority of the people on the committee were formed. There were members from the CDC, the NIH, the VA, BARDA, and then specialists in infectious disease, critical care medicine. We had pediatrics pulled in, pharmacists were on the committee. Many different specialties pulled together very quickly and then organized. And so part of that, it became the full-time job of the executive director who was appointed, and she really worked with us, really organized us as a group. And this happened so quickly, and remember that there was not much information or evidence around any of this. The disease was happening quickly. We were learning about it from areas of Europe that had been hit. When I think of in Italy, they had a lot of these cases. They were giving us the information very quickly about how patients were deteriorating from a pulmonary standpoint on oxygen, CPAP hoods, going to ventilation, and then the mortality rate was quite high. So we were trying to learn, how do we ventilate and support these patients? There were no vaccines. There were no drugs to speak of. The trials were happening very quickly as they could include patients. And so when you look at the beginning guidelines, again, for critical care, some of these were adapted guidelines from sepsis initially. And then for the treatment guidelines, again, as data emerged, we started to incorporate that. There were certain treatments in the very beginning that when we think about ivermectin and hydroxychloroquine that were initially, people were pushing for them, but there wasn't good data. And as we went through, that was the one thing, is the formation and the structure of the committee and the ability to review in different teams, kind of divide and conquer. We could look at the literature and then bring it back to the committee as it emerged and then vote on those to make recommendations. And where there was not clear evidence that something was helpful, we made a recommendation that we could not, decide for or against this. And how we would handle that is early on, a lot of it was based on people's clinical practice and expertise. So it was really expert opinion that then started to move toward evidence as more and more was provided to us.
So is that committee still meeting now? And because the science is still evolving with COVID-19. So I'm just curious as to what the long-term work is.
So our committee, we actually disbanded as of June of last year. And so our guidelines were archived at that point. And so moving forward, the other professional organizations have kind of picked up that baton. I don't really see them being updated as often as we did, because we voted. There were so many times that we actually voted. It was actually on a weekly, sometimes twice a week vote, based on what was presented in the meeting as to what level of evidence we would give and recommendations we would make. And when I think about that, the amount of times, and I had it here, that we voted on recommendations 438 times.
Wow.
And these were updated over times, and that the guidelines were 71 updates for the guidelines themselves from the first time to the last time. The things of 50 million page views. So this was an ongoing living document that was updated constantly, and sometimes with every iteration, only certain sections were updated. But early on, the work was tremendous of this committee and the support structure behind it. We couldn't have done this because, remember, everyone who was on this committee was doing their full-time job taking care of COVID patients, and then on this committee meeting at least twice a week. So the disease will continue to evolve, and I think a lot of the work that we're going to see is going to be around drugs. We start drug development. We started to see the critical care piece tail off as not a lot of the patients were going to the ICU anymore. And so, there were certain areas that we didn't update or certain areas that were retired. But initially, all of the things that we saw within the guidelines were, I would say the majority of them, were based on emergency use authorization by the FDA. They had granted that for a number of therapies, and I'm sure we'll talk a little bit more about that, but very few of these therapies. The one that I can think of was the Paxlovid, which actually then became fully FDA approved. But at the time, all of these were under EUA.
Well, that's a perfect segue to my next question. It's hard to believe that all of that work was done in such a short amount of time. But can you explain to our listeners what the EUA is and give an example of why it's so important in this rapidly changing environment?
Yeah. From the standpoint of an EUA, it's not the same as a full FDA approval or licensure. But what it is that if we think of any type of intervention, let's say, initially convalescent plasma was one that then later that was kind of like we didn't recommend it. Or any type of the drug combinations that came out for use by the FDA, including the vaccines when they were initially developed as well. And so the things that the criteria for an EUA are that we believe that whatever intervention we're doing is going to have a reasonable benefit in either the diagnosis or treatment of the disease process that we're seeing, and that the benefit outweighs the harm. And thirdly, that there is not something already approved that will allow you to treat this condition. So those are really the three conditions of an EUA. And again, it's not a full FDA approval. So you can see how fast things moved. Again, we could implement this treatment because when looking at it, you could see that things were helpful. One of the things that I think about was, remdesivir combined with dexamethasone. That was one of the earliest things in combinations. And as a matter of fact, it's intervention as things were developed and drugs were developed over time. When we looked at the monoclonal antibodies and the combinations of those as they came along, these were given EUA approval to be used for this purpose. And our recommendations changed over time, whether it was approved or not. We recommended things and then didn't recommend them based on the changes in the COVID virus and its resistance and the way it was morphing. There were things that we initially had recommended and then didn't recommend later based on the changing disease process.
Just for our listeners, I want to make sure, because we jumped in and started using EUA as an initial, and just to clarify, that's an emergency use authorization. So it's usually an authorization outside of FDA approval because it's too soon to say, right? The
Correct.
therapy is working or not working.
When you think about what it takes to bring a drug to market, the process is quite long. And in the name of safety and making sure that it works, in these circumstances, it's much more abbreviated. It's we have a reasonable belief that this will work in this condition, and that again, benefit outweighs harm, and that there's nothing else. There's no alternative. And so, because of this disease state, there were a lot of these treatments were approved under EUA.
John, I understand that you had a personal experience with your brother and his utilization of an EUA that ultimately changed his clinical course. Would you mind sharing a little bit about that?
Sure. So this was about November, and so we were fully into the pandemic. And one of the things that had happened is, as we developed the guidelines, the use of remdesivir and dexamethasone, that combination, anti-inflammatory and antiviral, were showing improvement. And a decrease in the duration of the disease and improvement. And so we were seeing that this was occurring in patients who were hospitalized with escalating oxygen requirements, meaning they weren't on oxygen, then they were, and that we were seeing the oxygen needs go up. And my brother was in a hospitalized. He was hospitalized with COVID. He was having shortness of breath. Goes to the ER. They admit him to the ICU. And he was in a very good community hospital. I think about this. He calls me on the phone, and I'm talking to him like, "How you doing?" He's like, "Well, not so great. My oxygen saturation is going down. They put me on oxygen." And I call him back later, and he went from, a couple of liters up to 4, and his saturation was not great. And so the guidelines, we had just voted on and recommended this, and I asked to talk to his attending. And I got the physician on the phone, and I told him, I said, I'm really concerned about this. I said, I'm on the NIH. I had to throw that in. I'm on the guidelines committee. And I said, we have these guidelines, and I pointed him to the website, and I said, he may be a candidate for this combination therapy. And he was very respectful, and he said, yeah, we're seeing more and more of these patients. And we had this great conversation. And he did go to the website, and I talked to him about the dosing, and he went and he looked at it. I will say later that afternoon, he started him on the combination of remdesivir and dexamethasone. It was quite striking. Within about 24 hours, his oxygenation improved, he felt better, and we did see a reversal of the course. And it was kind of, one of the things that I thought about is, had I not been on the committee, had I not known about the guidelines, and you were a patient laying in bed with a family member who doesn't know these things, like how many people would have known this? You look at the use of the guidelines internationally, nationally and internationally, the page hits. That was the first thing that we would look at every meeting, was what have been the number of page accesses, and we would have it broken down by the type of therapy. And the goal for me was really just to make it known that these guidelines existed, because I think it was publicized, but to the patient in the bed, and perhaps, you're not at a university hospital, you're at a community hospital, or you're somewhere, like, how do we get this word out? And I think we had those links, and, through professional organizations, we made our members aware of this. But again, there's these pockets of clinicians that might not have known this. And I think as time went on, it became more well-known. But what was important is that you were always looking at the guidelines, because they were changing. And they were changing with each publication, iteration, but behind the scenes, they were changing week to week and what was being recommended.
Definitely a very trying time, but I am so glad that your brother, improved so quickly thanks to you. And
he did. And I continue to use that as an example of, how we need to use evidence and how we need to make sure that we have access to the latest and the greatest, not only through the guidelines, but related to any type of therapy we provide our patients.
Well, and a lot of those decisions, though, weren't always popular. and somewhat controversial. So how did you and the panel members handle those concerns and those unhappy, those people that were unhappy with those decisions?
Well, we can start with early on when hydroxychloroquine was initially, thought to be something, we're looking at it. And when the evidence didn't pan out, our leaders had even met with members of the White House team and said, this isn't panning out. Like, this is not something that we can actually make recommendations to use because it's not a therapy that's showing promise. We had this happen with convalescent plasma. Toward the end of the guidelines, we had pharmaceutical companies say, look, these are our trials, like this is what we're seeing, this is data. We think this should be given kind of a thumbs up or recommendation as opposed to we cannot recommend for or against. There were pressures to individual committee members, emails. Some of the people that were at the higher levels received, emails. I remember being at a professional conference, and after speaking, there was a person in the back who was like, hey, I heard you're on the committee, and kind of followed me to my next talk. So there was constantly, I would say, pressures to look at data and actually say that this is, this has promise, and then giving it a stamp and saying that, we recommend this. But all of the decisions that were made by this panel were based on the evidence and the grade of the evidence, and independently, these decisions were made based on the committee's votes and based on the available literature. And as it was hard because there were some trials that would come out with smaller numbers or inconsistent results. We were asked to look at them. We invited to the committee meetings, we invited not only scientists, but companies that were coming out and they had their trials and provide us the data. We would see their data ahead of its publication, and essentially we kept that confidential because this was going to be published information. And the reason that we got to look at it ahead of time is they wanted us to see it so that we could look at it and decide how it fit into the guidelines and whether these treatments could be recommended or not recommended, or we couldn't make a recommendation one way or the other. And I would say that, although most of these were professional interactions, there was one day I opened up my email and I got an email from a nurse that was an advanced practice nurse, and she basically berated me for being on the committee and supporting vaccines and it was one of these things where it kind of caught me off guard, because as a person who's on the committee, you realize the work you're doing. That was only a small taste. I got one email. There were other people who got others, and including our co-chairs. So even with the best intentions of what you're doing and the work that you're doing, not everybody was on board. And there were a lot of pressures. And I think that was early on before there was a lot of data, but it continued to happen throughout. And I can say as a committee member that the work of this committee was so above board. We only made recommendations when the evidence was there and we felt comfortable. And even among ourselves, there were, clinicians that said, well, if I had a patient in front of me with this, I probably would give this or do this. So it was in their professional opinion that in the absence of widespread data, if I had nothing else to do, I'd probably consider this therapy. And sometimes when we, wrote these recommendations, there were caveats that said some panel members would, based on their experience, but we couldn't make a recommendation without strong data.
The work that you, along with the other committee members, on the NIH panel was very, very impactful, and I'm sure saved many lives. After this once in a lifetime, hopefully, experience, something none of us ever want to experience again, but we probably need to continue to learn for a possible next time. What lessons do you feel that nurses at all levels should take away regarding this on using their voice to advocate for nursing practice?
So I think, again, the pandemic did take a toll. There were nurses who were practicing, who were no longer practicing. They were heading toward retirement, thinking about leaving. There were new nurses that, came into the middle of this. And we were not prepared for this. As a nation, as a world, we were not prepared with this, with our supply chain. I think that was one of the things that we realized is that, there has to be redundancy in supply. And we learned this in disaster preparedness. And I think that's probably one of the first lessons I would say is that as nurses in your hospital, ask those questions where you practice is what's our disaster plan? What's our hospital disaster plan if these things were to happen? We don't think about redundancy of supply. I often think about, if there's a disaster within your community and you're like, well, I run out of this, but I can go to my other institution that's in network or perhaps my, trauma center that's down the street, but you're all going to be in the same situation where you're all going to need the same things. We fell short with things like PPE, specifically masks. We worried we were going to run out of ventilators. That didn't happen in the United States, but it was a concern. So knowing what your disaster plan is and making sure that nursing has a place at the table and can be part of those plans when you're going to need to expand your ICUs. We learned about the importance of telemedicine and how that was used not only to support nursing, but also respiratory therapists that had many, many ventilators, and they had people in these hubs that could actually guide treatment. Learning, what we saw in the pandemic is transferable to other infectious disease situations, and how can we quickly know to set up alternative care areas, isolation areas, expanding not only equipment, but our training very quickly. So what are the sites that we have available? What are your resources within your institution? But then being able to look to your professional organizations like AACN and SCCM that had set up very quickly. And I remember this as being on the board. There was a lot of work that went into developing not only websites, but educational programs around respiratory disease, the micro-credential around COVID. These things are transferable to other disease states, infectious disease. We did not and were not prepared for the mental health stress of our providers. And I think that would be something that I would give voice to, not only within the institution, because I saw this even in trauma centers before the pandemic, is we have supports in place for the family, but we don't have good support in place for the staff. And so how does that happen in an ongoing basis? Making sure that we're at the table when these decisions are being made and standing up as AACN did and say, hey, there's a vacancy here. We don't have a nurse at the table. So doing that within your institution and making sure that you're on all the committees, but especially those committees for disaster preparedness, because at the end of the day, when everything was being stressed and we were talking about alternative care models and staffing models, we had to move CRNAs to help the respiratory therapists. We had OR nurses moving to the ICU. We had floor nurses moving to the ICU. So what's your plan? Because it's at the national level is one thing, but at the end of the day, what it came down to is what happened locally in your institution and what resources could you muster and put in place. And I think that having kind of online or web-based just-in-time training for certain things was very helpful. I know at the time when I was at Penn, there was a specific web area that actually had resources on how to prone, kind of algorithms for how we're going to ventilate somebody and if these things changed, because there was that pyramid approach where you had critical care nurses and physicians supervising those that were not critical care. What type of courses can we set up within our institution, and how do we regularly train not just the ER for the disaster that's coming in, because that's where disaster drills focus. They don't ever really make their way up to the operating room and the ICU and the floor. What's your process for expanding that to now I need to make the PACU an ICU. Now I need to make other areas an ICU, even down to the equipment that you have in place. Can I care for a pediatric patient should they show up in my institution? How will I be overwhelmed if the people that are high technology in their homes or in other facilities lose power, and now they're all showing up in the institution. These contingency plans have to be in place. Just kind of in addition to that, like what are the community resources and what do you have available to you locally? Because in any disaster, it's always going to take time for the state and the nation, the national teams to respond.
Well, John, I just want to publicly, one, thank you for your time today, but two, more importantly, to thank you for all the time that you spent on this NIH panel, because I know you were dealing with your own issues within your institution, your home life, and then to give the amount of time that you gave to this is just incredible. So thank you on behalf of all of AACN and all of nurses across the nation for that work.
Thank you. It was not thought that it would take 4 years, but it actually was 4 years of commitment, but also what a wonderful opportunity to be able to work with the team that I did and to be able to contribute. And again, who would have thought it would have started out with an email from Connie of have an opportunity you might be interested in. And, again, what I would say to people listening to this is be involved, and join AACN, but also be involved with your chapters and your professional organizations, because I've gained so much in the relationships I built. And this is kind of how I was involved and, was able to contribute is because of that relationship with AACN and for the people that knew me and knew my background and knew my experience. And it was, as I said, it was an honor to do it, and I greatly appreciated the opportunity.
We'd also be remiss if we didn't say thank you to Connie as well for her bold voice in contacting NIH and saying, hey, we need a nurse on this panel. So her advocacy work will continue to impact many from years to come. So I also want to thank our listeners for joining us today, and we would love your feedback on this episode and any suggestions for future topics. You can contact us at podcasts@aacn.org. We will see you the next time. Thank you.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's membership, offering members special discounts, clinical resources, and unlimited free CEs, with information on how to join available at www.aacn.org/discoverAACN.